It's not, it's good therapy. It solves the problem in some men, but it is expensive and it comes in many forms, so compliance issues can exist, especially if they're given as injections. And if you're doing gels, it's a transference issue. If the men are germ freaks, they typically worry about the towels and who's touching them and is the kid getting a mustache and that kind of stuff for transference. So there are all these little issues, but literally it's 60, 70 years of the same thing. You're committing them to, it's not a pill, right? I mean, it's something they have to do for the rest of their lives. I guess you could say it's like brushing your teeth, but at $800 a month to somebody, it can be pretty expensive, and it may not be necessary. There's a variety of testosterone replacements. They're all about the same. They have different side effects and profiles. The worst one for injections is polycythemia, where you blood dope essentially. And I've had patients sit in my office with strokes and with pulmonary emboli and things like that because their trainers put them on it and they weren't followed by doctors. So, a lot of young guys can get out of control with it, and there's a lot of deal making going on with me and them. And here's what I'm going to do. You got to set your limits about what you're willing to do. And one of the keys of the lecture was some of the alternatives to testosterone replacement in young men with low testosterone is take care of the patient, listen to the patient, find out what's actually going on. Getting them to change what's going on is complicated. So you can support them with testosterone, bioidentical testosterone, meaning their own, with more natural means with pills, and make deals, and say, I'm going to try you out, we're going to get it up to a nice comfortable range, and we'll see what's going on, we'll see if you get better. And if you do, then maybe testosterone replacement is a good thing for you. But you can also maintain their fertility by not using testosterone replacement, which for men in the 20s and 30s becomes really important because, there is a thought that too much testosterone replacement will probably shut down the testicles at some point. Minor concerns, the large studies of 3 years follow-up, which I present, really talk about, no real side effects. You can have vision changes. One had for a clomiphene citrate patient had a blood clot in his eye. It's called CRVO. It was the only case ever presented in the literature. And I presented it to my group of fertility specialists, 200 of them, with about 20 years of experience each, which is 4,000 patient years of care. No one had ever seen it. And I have 400 patients on Clomid now. There's no long-term data. There's no FDA approval for this. There are probably equivalent supplements, pharmaceuticals coming out soon. One's called Androxyl. I don't know the trade name, but it got phase 3 clinical trials. But it's interesting that the trials are done, they show improvement, but they're a little hesitating maybe a little bit on approving it. And I think one of the issues is that we think about 2/3 to 3/4 of men with late onset hypogonadism, which is not the group we're talking about, but men who are older whose testosterone levels fall from andropause or whatever it's called, might be due to secondary hypogonadism, which means that they might be able to respond to these kinds of agents and not need testosterone replacement. So it would be more physiologic replacement at more physiologic levels and patterns using pills, and that's hard to beat. So I think that one of the issues with the FDA is, and it may not be true, I wonder a little bit why it's delayed, is because it sort of could be a blockbuster drug. And the question is it really a disease? Is late onset hypogonadism the natural history of being an older man, or is it not? And it's kind of an interesting problem. Do you put a blockbuster drug out for something that occurs naturally?